PPROM, but just make sure to like kind of note the, compare and contrast. I think that is what made it make sense for me. So imagine that you have a patient that is a 21-year-old G2 P0101, and she is currently at 28 weeks. And this is dated by a first trimester ultrasound that had been done at the ER. And then she had minimal prenatal care because she was worried she'd have her Medicaid until about a month ago. So she came in for an appointment a month ago. So really limited prenatal care. You've got good dating, and you do have another scan on her. So that's good. You take a brief history on her. Every pregnant person, you go in the room, and the nurse had told you that she's complaining of contractions. So you walk in the room and you're like, tell me about, so you're contracting. And she said she's been contracting every 5 minutes for the last 2 hours. And she denies any leakage of fluid. She denies any vaginal bleeding, and she endorses fetal movement. And so just like your basic questions. And then you do find out her pregnancy history. So with her first, she actually had a preterm delivery at 28 weeks. It was a vag delivery, and she did have chlamydia at that time. And then when she was seen at her clinic visit at that 24 weeks, she did have a UDS that was negative, and she had no placenta previa. So those are all kind of things that you're thinking of. And so you walk into the room, and what are things that you're going to do for her? How are you going to evaluate her? What does her strip look like? So her strip looks good. It's like 130s, category 1. So she's got act cells, 10 by 10, because she is less than 32 weeks, and she isn't having any D cells. So that part looks good. She actually is contracting every 5 minutes, but you are aware that sometimes on preterm labor, like their uterus is little, and sometimes like you can't, or she could be a really big girl and like you don't really see any contractions. So just know you could be a little bit tricked on that. But you actually can see contractions every 5 minutes, and she does kind of wince with them. So it does seem to be uncomfortable contractions. And so what are you going to do in this situation? How are you going to evaluate her? Okay, so you ask her a little bit more history, and she's had nothing in the vagina times 24 hours. She did try with some Tylenol, and that didn't seem to make, and some Benadryl, and that didn't seem to make any difference. She's still having them. And she has drank, she drank some fluids. So she had a big glass of water. So.
Systemic symptoms like fevers, chills, signs of infection.
Nope, no fever, no chills. She's just like, oh, doc, I'm really worried. Like, this is what it felt like last time. I'm having a lot of pain.
No vaginal discharge.
She denies any significant vaginal discharge, and she broke up with the guy that gave her chlamydia last delivery. So it's a different dad.
And have we had treated that chlamydia?
Like, they did treat it. Yes. Yes. Okay. And they had swabbed her at her ER visit. And you don't have, like, she was negative for gonorrhea and chlamydia. Sorry. Okay. So you want to start with a speculum exam. Okay. And then kind of tell me what you want to do during that speculum exam. What do you want to collect? What do you want to look at?
FFN.
Okay, so you're going to collect an FFN, and you kind of started going down this path. So, like, what would be, like, when you're thinking, is she even a candidate for an FFN? Like, what are the things that you're thinking of? Like, what week's gestational age does she need to be?
32.
And then
No vaginal bleeding, lots of fluid.
Yep. And this one's a little bit of a detail that I don't know comes up very often, but no placenta previa. Okay, so you know all that. So you collect FFN, and you're going to wait to decide whether or not you're going to send it. What else are you going to collect?
UA.
And then there's one that's easy to forget.
Oh, GBS.
GBS, yes. Okay, so you collect all that, and then you got a UA with culture. Okay, and then on your speculum exam, you're trying to like assess like if you think she's dilated or not. And she doesn't look like she's completely closed. You didn't use a Texas swab or anything to decide. But now you have to decide, are you going to check her, yes or no? Are you going to do an SVE on her?
Yeah, you can.
Well, and do we know where the placenta is?
Yeah, she did have placenta previa. Yes, no placenta previa. I forgot to finish my. It's excellent thinking though. You have to be constantly thinking, is she ruptured? Does she have a placenta previa on these pretermers? Okay, so you can do an SVE. And so what I would always say on a preterm labor one, you can do an SVE. And I always say people have sex their whole pregnancy and that does not put them into labor. So your little gentle SVE is not going to change things if they're intact. So just like concept. So you can do the SVE and she's 350 -2. She's soft and it's pretty interior. What else are you going to do as you're assessing her here? Yeah. And she is vertex. Okay, so you have this information. And then are you going to send the FFN now? Is there anything else on ultrasound you would do? Like what are you gonna do from here?
Oh, yeah, cervical length.
So you could get a cervical length, but with her already being 3 centimeters, usually people won't get a cervical length. So you have to think like, if you're going to spend money on a test, is it going to change what you're going to do? So if you just look at this objectively, I have somebody who's previously had a 29-week delivery. She's coming in painfully contracting. She is 3 centimeters dilated, just have limited prenatal care. There's nothing that's going to reassure me like, oh, I'm just going to send you home.
Yeah.
Like there's nothing, I can't spend enough money like that. The FFN and that's not going to change it. And we can go into more details of like when I would do those. But for now, like, I mean, do you want to admit or send home? Sorry, I'm gonna get that away. Okay, so then in general, like for an admission on a preterm labor, I guess preterm labor rule out, like what are the general orders that we're going to be doing for her?
There is magnesium.
So the magnesium, and why do we give magnesium? Yeah. So magnesium for preeclampsia is neuroprotection for mom, but for preterm labor is neuroprotection for baby. Excellent. What else we're going to do? So we're going to do the antenatal corticosteroids. And then what are the benefits of the steroids? Yeah, so it's lung development. So generally speaking, it lowers the risk for respiratory distress in preterm babies by making the type 2 pneumocytes make more surfactant. And the reason that you don't give it lower, usually at 24 weeks, like the baby should have type 2 pneumocytes, but like younger, it's like hit or miss on if they do. So sometimes that's why you repeat it. So just to be aware, that kind of makes me remember it. So ANCS lowers respiratory distress. And then I have started, I think it's also helpful to know the other things that it does. There's a couple other things there's 3 other things that it does. Do you guys know this? There is a little bit of, oh, is it not recorded? Yeah, stay on the call. That is true. There is a little bit of concern that like steroids might knock off some IQ points, I guess, certain levels. So there's a little bit of debate. But this is just like the good stuff that steroids can do. Good that way. For like, what are common like NICU? No. Like bad things that we look for, like
Necrotizing.
Yeah,
yes,
for mouths.
yeah. So it lowers the rates of necrotizing enterocolitis, and it lowers the rates of IVH, and it lowers the rates of death for the pretermers. These are all good things. And so that's why it is. This is really why we're trying on preterm labor. We really can't completely stop preterm labor. You kind of push pause on it. And this is really the benefit, is being able to get them the steroids in. So it's a big deal. And then what else are we going to do for them? So we're going to do antibiotics, but what antibiotics specifically? Not late seeds. It is ampicillin usually, so it's just GBS prophylaxis. And I'm gonna have to give a whole other talk about, so it's usually if they're allergic, then you have to know, if you did sensitivities and they were sensitive to Clinda and erythromycin, then you can give Clinda. If it's resistant and they don't have anaphylaxis, then you can give them a cephalosporin. But if they are unknown sensitivities or they're resistant to Clinda, then you have to give them vancomycin. That's a whole other. Okay. And then what else do we also consider? Yeah. This is kind of a regional thing. So you have different tocolytic options. So you can do your calcium channel blockers. You can do indomethacin. We don't use terbutaline in this hospital for it. It hasn't really been shown to be an effective one, but if you're in a small town, they do use that a little bit more often, so I do mention that. And then magnesium used to be used for tocolytics. However, it doesn't really work very well, so it's a little bit semantics where we use it for this, but I mean, we're kind of hoping maybe it helps a little bit with the tocolytics, but this is why we're using it. So it's usually nifedipine or indomethacin or a combination of those. And so with the ampicillin here for the antibiotics, I also want to mention that you would just continue that as long as either she's going to deliver or not deliver, but if she came back GBS negative, then you could stop that in this scenario. Okay, so then jumping over to kind of comparing and contrasting with PPROM, let's imagine that you have the same patient that comes in, but this time she complains of leakage of fluid. The PSU nurse calls you, and they usually have done ROM plus. They'll say come see her, but I've got a ROM plus cooking, So you go in and you ask her these same questions, and she, plus or minus on the contractions, we can kind of make this case go either way. We'll say, no contractions, but positive leakage of fluid, positive fetal movement, no vaginal bleeding. And then we'll make the rest of the history is the same. And so, and we would, okay, I forgot to say here, we would repeat her UDS when she came into labor. I forgot to say that, we would do UDS here. So, and this, we'll say that she wasn't contracting all that much. So at the same time, so we're going to are we going to do a speculum exam on this patient? Okay, yes. Are we going to collect an FFN? And by this time, as you're have talked to her, she did have a positive ROM plus. So she's ruptured. And even if you were unsure, you would still kind of you have to act cautiously and act like they are, because that's the bigger deal. Are you going to do gonorrhea? Are you going to collect gonorrhea and chlamydia, affirm, and GBS on this patient? Are you going to do a UA? Are you going to do an SVE? So this is a big deal. So this is one of the big, huge differences. So while it doesn't matter if you check somebody that is preterm that is intact, it does matter. It has been shown to scientifically, it shortens their latency period, meaning the time between their rupture and their delivery. And you're trying to make sure that that's as long between those two as possible. So, so I would not check her. With that being said, I will say in the little asterisk, or parentheses, is if you were in, if say I was practicing in Dodge City, Kansas, and I had to transfer this patient from Dodge City to Wichita, so, 3 hours, is it sort of? Yeah. Okay. If it was, then you frequently would, because that patient is yours until it enters the door of the next hospital. So you might get confused at times seeing where people are checking, but that's kind of why. But you do the best that you can, really just looking with the speculum exam, and you could use a cotton swab, and try to see if it looked like it was dilated or not. Sometimes you will do a speculum exam and you will see the baby's head, and you're your diagnostic dilemma is, she's dilated. but we are in, I would say, the warm bosom of a tertiary care center. So our woman is where she needs to be to deliver, and you have NICU there, so you don't need to be checking her. However, ultrasounding for presentation, this is a big deal because these are actually pretty hard when you have somebody who's malpresentation, like it's breech, because you have to decide when are you going to cut them, like when are they in the labor enough to like cut them. So that's a whole other thing. So for this patient, let me back up 1 second. So say that this patient, she had such a convincing story, like you really think that she's ruptured, but the ROM plus was negative. What would you do in that scenario? Yes. Yes. So you would do a spec and you would do like call it the triple check. So you would do the nitrazine, you would do pooling, and you would do ferning. And in our hospital system, this is a little side note, you collect 2 different slides and do one in the resident room and then send one down to the lab, because in order for us to read it officially, everybody has to get like every 6 months signed off on being qualified. And so that's why we have to do it this way. And if so, send down that second slide, just please. But you should, every block that you're on OB, please practice doing this, because a lot of hospitals are not going to have a ROM plus. Like I don't even think Wesley does it. I don't know if anybody knows off the top of their head.
They don't do it. Yeah.
Okay.
They
Yes.
just have ROM plus.
They have ROM plus.
Mhm.
Okay. I just know a lot of small towns don't have ROM plus, so you guys just make sure you know how to read a ferning slide. And so when you collect it from the posterior fornix. But going back to this. So are you going to admit this patient or not? Exactly. You're going to admit. And then are you going to do neuroprotection with MAG?
Yes.
Yes. And then you only do it to 32, and actually that's even the same for this. So 32 weeks. Are you going to do steroids? Are you going to do antibiotics? What antibiotics are you going to do? Okay, so I'm hearing some. Okay, yeah. So ant for how long? So 48 hours of ant, and then followed by amoxicillin. And then you're also going to do a dose of azithromycin. There are various regimens, so be aware of that. Like when you look in your red book, but it's in the order set. So just know that you are covering for more than GBS, like you're covering polymicrobial, and so that's why this is the standard. And you continue this regardless if they come back GBS negative or positive. Like this is like, even if they're GBS negative, you would continue this for 7 days and hopefully they stay pregnant. If they're GBS positive, you would continue it for 7 days. But then when they actually go into labor, then you would restart your GBS prophylaxis of just ampicillin. But honestly, like usually when they go into labor, by then they have choreo. So then you would actually go with your choreo antibiotics, and that's a whole other talk too. And then would you do tocolytics? So no. So this is that whole thing. This is another difference. So I think knowing the slight differences on this, I really think makes the attendings trust you more. So on preterm labor, it's okay to check their cervix. And then their antibiotic choice is really the GBS prophylaxis. If you have PPROM though, you do not want to check their cervix unless there's very compelling reasons why. And there could be a time where she's like, I would caution you, like, even when they're screaming, sometimes, like, I've had it where you're like, well, she's obviously going to deliver at any second. And then you check them and they're like, once and you're like, oh, that was, so just be aware. But sometimes you look and then the baby's coming, and then you're like, that's fine. You can check. And then you have to know that there's different antibiotics for latency. And you have to know that you don't do tocolytics. But at the same time, you do MAG, but you don't call it a tocolytic. So it's kind of that semantics. But that's kind of some of the big highlight differences. What questions do you have? Okay.
I would say some quick attending specific differences. So by the book, then the MAG is only up to 32 weeks. Dr. Scrapper will only do up to 32. I would say most of the other attendings go up to 34, both for preterm labor and PPROM.
Yeah.
More so for preterm labor, but like they basically are all like, yeah, whatever, probably up to 34. There is one study that showed it beneficial up to 34, but they didn't differentiate whether between that 32 to 34 week. So probably most of the benefit was from below the 32 weeks. It's just that this study says, okay, hey, it is beneficial up to 34, but probably all of that was due to the less than 32 weeks.
And I will say, it seems like, I think Wolf and Scrapper are the ones that stop at 30. Correct me if I'm wrong, 32.
Like
But
Brantley for
is
sure
definitely at 34.
Yeah.
So
That's
Yeah.
the same for steroids. It goes up to, is it 36 for steroids?
36 and 5.
36.
Yep.
Yep.
Mhm.
And the 36 and 5, you think about it, it's because it takes 2 days to get it in. But then there's still a little bit of debate about, I mean, that got adopted a little bit faster than I would have thought it would, based on when you look at the the benefits. But, you definitely get benefit on steroids up to 34. And then that 34 to 36 and 5 is a little bit more of that gray zone, and it's made it a lot more complicated from our perspective. But if you have somebody who's already had steroids and then they're in that 34 to 36 and 5, you don't repeat the steroids. If they've never had steroids, then you could consider repeating them.
Yeah, the only time you would repeat them is if they're less. They've had it a while ago.
Yeah.
They present at least 4 weeks after they've had it, and they're still less than 34, and you expect them to live within the next 7 days.
Yeah.
So that's the only time you would repeat the steroids.
And it's interesting. There's a lot of history when you look at the way things used to be done. This was even before I was a doctor, but they used to do like weekly steroids for some like high risk patients. It turned out that wasn't a good idea. They don't do that anymore. But just like the evolution of steroids is pretty.
And then 2 other quick attending things. When you're doing the spec and you're looking for pooling, like Dr. Brantley is going to say, did you make them cough?
Yeah.
To like have Valsalva to see if they have leakage with there.
And sometimes it's like so obvious that they're pulling. Hopefully you've all seen it. There's times where you're like, oh yeah, there's pulling. And then other times you're like, can you see that? So this coughing in that scenario really does help you make that clinical decision.
And then one other last thing about the FFN. So why is FFN helpful? It has really good what? Yeah, it's really specific. It has a good negative predictive value. So if that is negative, it's like a 98% chance that they will not deliver in the next 7 days. But if it's positive, it's not that super helpful. And then the one other thing that I had an issue that I messed up one time as a resident, we collected it. It was going to send it. The patient was like kind of contracting, not really, but they're already 3 centimeters. So technically on the package insert, it says if it's 3 centimeters or greater, you would not send it just because you're like, well, they're far enough dilated that it's not going to really matter. You're probably going to keep that patient. So does that make sense?
Well, it helps me to think, if I'm going to spend that money, is it going to change what I do? So, and really when I was in Pratt, it took 48 hours to get back the FFN result. So by then, if she's still pregnant or not. So it didn't really change what you were going to do. So I was like, okay, well, there's no benefit of that. So it's good.
For your class, do you want to related questions?